Hi, thank you for listening or participating in our discussion today. My name is Dr. Raymond Yao. I work with Heart Hospital in New Mexico. I am the current Cardiogenic Shock Program Director, and today we're going to be talking about a new vision for our region. These are my financial disclosures. So we're going to talk about the background about cardiogenic shock. We're going to talk about the idea of transforming a institution and care model to incorporate a cardiogenic shock team and the importance of cardiogenic shock teams. So this is kind of how it all started. About approximately 6 months ago, I was doing outreach in Farmington. I met with a cardiologist there, and we were discussing a case about a young man who was in his 40s who presented with acute MI and shock. The patient had percutaneous coronary intervention to his culprit vessel. A percutaneous left ventricular assist device called an Impella CP was inserted into the patient. However, that patient still did poorly. And that cardiologist asked me what I would do. Dr. So-and-so, by these numbers, I would have escalated therapy. And he asked me, what do you mean escalate therapy? Well, I mean, increasing support with other devices such as Impella 5.5, ECMO, and strongly consider transfer. And he didn't really think about these issues, and this is what we routinely try to practice at our institution here, but we don't really have a formalized program to do this. And this is what got me started to think, hey, we need to improve care for a population of very susceptible patients who have very high morbidity and mortality. And the model which I really emphasize on how we should kind of mimic the successes is our STEMI program. Our STEMI program for the past 10 years has always been improving. According to national registry data, we rank in the top 96 percentile for STEMI care delivered here in Albuquerque. And these laurels are, it was extreme hard work by our partners here, and as well as Maria Atencio, who I'd like to give a lot of credit to. What's very important about our STEMI program is that everyone involved is held to a certain guideline and is held accountable to following protocols. The reason why we're so successful, because we have a systems of care. We have standardized protocols, we emphasize early recognition, and we review quality data. And because of these principles, this is why we are successful. Now, if we adopted all these same principles to shock, I think we could achieve very similar results, maybe. So this is slides for the past 50 years in modern cardiology. There's a certain subset of patients where all the care, all the technologies that we haven't really improved outcomes. And these are patients presenting with acute cardiogenic shock, especially after an acute MI. Mortality has stayed stagnant. We're only 50% at best, and this is conducted over many clinical trials with the use of mechanical support, pressors. We haven't really been able to budge the needle, only until recently. So this is charts showing, demonstrating starting from 1973 to 2016, cardiogenic shock survival is only 50%. But recently, with the work done by Bill O'Neill and colleagues in Michigan, he started what we call the National Cardiogenic Shock Initiative. And that initiative kind of paved way for what we're going to be doing here. And the results that they are seeing now is they're getting close to 77, almost 80% survival for patients presenting with cardiogenic shock. Although this is registry data, multiple institutions who have implemented shock teams and followed a shock protocol are seeing very similar numbers in survival. These are our percutaneous LVAD numbers. So we do approximately 70 to 100 percutaneous LVAD a year with Impella device. In blue is the percentage of patients who are having high risk PCI. In pink are the patients presenting with cardiogenic shock, and in green, those are post-surgical patients. So as you can see, majority of our patients are presenting with us in a very late fashion, meaning they're getting percutaneous LVADs in a unstable state rather than having complex coronary interventions. And our survival here, I could say, is approximately 50 to 60% at this time. However, we have not really gathered the data and gone through it thoroughly. So another problem with identifying patients with cardiogenic shock is that the definition of cardiogenic shock is very vague. This is the official definition. So cardiogenic shock is a low cardiac output state resulting in life-threatening end organ hypoperfusion and hypoxia. But when we take it into a clinical circumstance, is how does any physician or care provider say, hey, they're in a low cardiac output state? I think this is one problem that we have not done well as in healthcare, is define what cardiogenic shock means clinically. So this is part of our shock algorithm in identifying patients with cardiogenic shock. So patients with cardiogenic shock, majority of them will present in either two fashions. One, they'll be presenting with ACS, acute coronary syndrome, meaning they're having an MI or unstable angina, elevated troponins and whatnot. Or they're going to be presenting with acute decompensated heart failure. Having this as your primary clinical criteria will help distinguish patients with cardiogenic shock versus other forms of shock, such as hemorrhagic shock or even septic shock. In addition, other criteria for shock are that they're going to have a systolic blood pressure less than 90 millimeters of mercury for 30 minutes, or the use of inotropes to maintain a elevated mean arterial pressure, elevated biomarkers such as lactate, and other forms of injury, such as if it's acute kidney injury, rise in renal function or creatinine, liver injury, ASTs or ALTs, lung injury if they start developing pulmonary edema and the need for BiPAP therapy, and obviously a altered mental state is also considered part of end organ hypoperfusion. For patients who have had hemodynamic invasive monitoring at an outside hospital, we would highly recommend the use of a SWAN to discern whether it's cardiogenic shock or non-cardiogenic shock, and a cardiac index of 1.8 not on any inotropes, or a 2.2 on inotropes. Cardiac power output, which is a big determinant of how patients, one of the strongest prognostic factors of how a patient is doing, is what we call cardiac power output of less than 0.6, which would be calculated online. A PAPI score less than 1, which is an indication of right ventricular function, and a wedge pressure greater than 15. So why implement a shock team? Well, as I've described earlier, cardiogenic shock is a very complex syndrome. It takes multiple different specialists to help identify shock, and cardiogenic shock obviously carries a high mortality. Patient management remains highly variable. I think treatment of cardiogenic shock, it's not standardized. And what the reason for implementing a shock team is that protocols reduce this variation. It encourages early identification and helps expedite treatment. So the goals of the shock team are as follows. It's to facilitate early shock recognition and expedite multidisciplinary discussions regarding evaluation and management and the need for early mechanical support. This is a study published last year in the Journal of American Cardiology comparing 20 institutions with and without shock teams. So I think it was 14 hospitals in the shock team arm and 10 hospitals without shock teams, and compared their outcomes. There's 3 key findings when we compare hospitals that use shock teams and hospitals that don't. Number 1, institutions that use shock teams have better invasive monitoring. Their usage of Swan-Ganz catheter or PA catheter, PA catheter use is 60% compared to 50%. Next finding is that overall mechanical support for institutions that have shock teams, there's lower use of mechanical support. This was largely driven by the use of intra-aortic balloon pumps for cardiogenic shock. However, institutions that had cardiogenic shock teams are higher use of more advanced mechanical support, which is the Impella devices, which can provide a lot better flow and stability for patients with shock. Lastly, the most noted is that institutions that have cardiogenic shock programs demonstrate better survival. So the model for which we are going to mimic is our cardiogenic shock program is one of the first early drivers of the National Cardiogenic Shock Initiative players, and this institution is called Innova Heart and Vascular. They are a hospital very similar to ourselves, located in Virginia. They do ECMO, treat adults and kids. They have a heart transplant team and an LVAD team. As you can see, their Impella volume is approximately very similar to ours. They have clearly documented their shock activations, which are about 200 to around 200 a year. This is the demographics on the left of their catchment area. It includes Maryland and Virginia. On the right is our catchment area in New Mexico and our transfer centers. So they started in a very similar position as us. However, they've already laid the groundwork for what we need to do to achieve a similar shock team program. They did early analysis and found of their shock team and their program, and while developing this, and there's basically they did a root cause analysis and found 4 key factors of why patients did poorly with shock. Number one, the first thing was fractured care. So there was no formal process for multidisciplinary discussions between the treating physicians, and which led to really suboptimal care and communication. Number two, the second thing that they found that was a problem was late detection. So patients were often too sick, very late presentation. By the time they'd arrive, the patient would have already multi-end organ failure, be on multiple pressors already. Number three, impaired access to care, so delays in transfer into a higher level of care system, which leads to late recognition. And variations of care. Not all cardiologists or those taking care of the patients were using similar therapies across the board. So these are the 4 main impediments to having a successful treatment for patients with cardiogenic shock. So this is their outline of their journey. It started in 2016, and now they're going on 6 years now, and have a very, very accomplished model on how to create a shock team. So this is their outcomes over the past few years. They started at 47% survival, and with initiation of protocols, coordinated team care, and facilitated care, their survival is in the 70% range. And like I said, this is very amazing because for the past 50 years, we have not moved the needle on survival. And now recently, with care teams, protocol driven, it really gives us a model to look up to, and it's very promising that they could achieve those results. So can we. They've also developed prognostic scores during their process on determining who's going to do well with cardiogenic shock and who is not. And these are the drivers, metabolic markers, cardiac power output, and other risk factors. They have established a stratification therapy and to use for treating patients with cardiogenic shock. If you need circulatory support, if you need ventricular support, coronary reperfusion, or renal or hepatic loading. So what's very important here is that shock is a continuum. It exists in multiple factors before the entire body shuts down. So the first stages of shock are what we call hemodynamic shock, where your organs are still getting some perfusion and they have not shown significant derangement yet. And once patients start getting into the second form of shock, what we call hemometabolic shock. So patients With hemometabolic shock, we'll have derangements in end organ function. They'll have elevated renal function, increasing right atrial pressures, derangements in liver dysfunction. And when you get into the stage of hemometabolic shock, it is a death spiral. That is what we're trying to prevent. We are trying to prevent patients from going from the hemodynamic shock and preventing hemometabolic shock. This is another slide showing their data demonstrating that if you recognize patients with shock early on and initiate early mechanical support to improve perfusion, you're going to have improved survivals. Every 60-minute delay in initiation of mechanical support leads to 10% increase in death. This is their stratification on the types of pumps or mechanical support devices that they use. They use very similar models to us, the Impella Tandem, VA ECMO, and VA ECMO with left ventricular venting. We have these similar technologies that we'll be instituting in our shock program. The idea is not only to create a system just for Albuquerque alone, it's really becoming like them and being a hub and spoke model for our entire Southwest region here. I think if we improve care here in Albuquerque and implement our shock team and our shock goals, we are going to change care for the entire region and improve mortality and morbidity for these very susceptible patients. So conclusions, cardiogenic shock, it's multifactorial. It's very, very difficult to diagnose right off the bat. That is why we should implementing a shock team will facilitate early recognition. We'll have multidisciplinary discussions and have appropriate care for these most very vulnerable patients. And we are going to start creating a hub and spoke model, and hopefully we could change the care here in New Mexico and this region. Thank you very much.